Good morning. I will be presenting on behalf of Medicine 4, rapid grower with slow recovery. So presenting Mrs. R from Kadapa. She was present with complaints of fever for past 15 days with complaints of breathlessness for 1 week and altered sensorium for 1 day. Coming to the course of events in her. So in March 2025, she presented to outside hospital with severe back pain. She was diagnosed as spondylodiscitis seen by L4, L5 decompressive laminectomy and treated with abscess drainage and treated with IV antibiotics. The pus culture has grown Klebsiella and Pseudomonas. The HPE is inflammatory granulation with fat necrosis. On April 2025, she has developed wound dehiscence with pus discharge in the site of surgery. She was advised debridement and rotation advancement of the flap. On which she did not undergo. From July 2025, she has developed high-grade intermittent fever with chills. Highest documented temperature is 104 degree Fahrenheit for past 15 days. Breathlessness for past 1 week, which is worsened to orthopnea for 1 day. For all the complaints, she was admitted in Kadapa with the above complaints and treated with injection piptas, doxycycline, and as her hemoglobin is low, she was transfused with 3 units of packed cells. In the hospital, she has developed one altered sensorium, which is excessive drowsiness and irrelevant speech for 1 day. Past history, she is a known systemic hypertension for past 5 years. She was diagnosed to have a coronary artery disease before 1 year and PTCA done, which details are not available. So on examination, her pulse rate is 120 beats per minute, which is regular. Blood pressure is 140 80 millimeter mercury. Respiratory rate is 26 breaths per minute, and she was using accessory muscles of respiration. She has pallor, bilateral pitting pedal edema, elevated JVP, and she also has cushingoid appearance with moon faces. Serious examination S1, S2 here with pansystolic murmur in the mitral area. A respiratory system, bilateral inspiratory crepitations in the infraaxillary, infrascapular, and intrascapular areas were here. Abdomen is soft, not distended. CNS examination, she's at the time of examination in the ward, she's conscious, oriented to time, place, and person. Cranial nerves were normal. Power 3/5 in all 4 limbs. And her sensory examination is normal. Absent knee and ankle reflex. Right plantar is flexor and left extensor and left is flexor. So coming to the syndrome complex, this 46-year-old lady with fever, breathlessness, with altered sensorium, with a background history of spondylodiscitis treated outside, now with infected surgical wound with features of heart failure along with new onset mitral regurgitation murmur. So probable disseminated bloodstream infection, most likely infective endocarditis with septic emboli. Investigation, her hemoglobin is 11.8, total count is 15,900 with a neutrophilic predominant 91 and platelets were 1,47,000. She has a mild AKI, creatinine is 1.41. Electrolytes, sodium is 136, potassium 4.1, bicarbonate is 20. LFT, she has a cholestatic picture of jaundice. So her total bilirubin is 2.17, direct is 2.13, protein is 5.9, albumin is 2.3 with the SGOT of 54, SGPT 14 and ALP 412. The echo done has showed a echogenic mobile mass noted in the anterior aspect of both mitral leaflets. AML 8 mm into 6 mm and PML 20 mm into 8 mm in size with a severe MR. In view of spondylodiscitis treated outside with the infected surgical wound, we have done an MRI spine with whole spine screening, which has showed a altered signal density with multiple small peripheral enhancing lesions involving multiple cervical, thoracic, and lumbar vertebra and intervertebral risk. Probable low-grade infection and In that, they have told us there is a peripherally enhancing lesion in the right parietal lobe and right cerebral hemisphere, suggestive of abscess. So now it's the infective endocarditis is multiple spine mets and brain abscess. So the interesting thing is the organism we have isolated is the non-tuberculous Mycobacterium abscessus. So the culture which we have sent on 3-8 normal blood culture, it has labeled as contaminants. However, after some time they have told us it's a Mycobacterium abscessus on further incubation. We have sent the LG medium culture, which also isolated Mycobacterium abscessus. The drug sensitivity we have sent for the Mycobacterium abscessus is multi-drug resistant, which is resistant to minocycline, moxifloxacin, and imipenem is also intermediate. So the final diagnosis is disseminated Mycobacterium abscessus with infective endocarditis, spinal and right parieto-temporal brain abscess. The possible source of inoculation will be the surgical site infection presenting with the heart failure. The few points about Mycobacterium abscessus. So non-tuberculous Mycobacterium are present in the environment bacteria, mostly found in the soil and water. They are actually opportunistic infection. It includes all members of Mycobacterium family except Mycobacterium tuberculosis and leprae. The most common cause of disease in human is Mycobacterium avium intercellare followed by abscesses. This Mycobacterium abscessus is a rapid grower, and it grows less than 7 days. In our patient also, it has initially grown in within 52 hours. So the difficulties in this treating this bacteria is the selection of antibiotics and resistance. So we have to like the regimens we can give is more than like one, not the one drug. It should be like one or two, like 1+2 drugs should be given. So amikacin, clofazimine, macrolides is the standard tool. All regimens should contain macrolides, but this Mycobacterium abscessus used to exhibit macrolide resistance due to Erythromycin ribosomal methylase gene. So it's said to be so until we get the sensitivity to macrolide, we stop ourselves from starting macrolides in Mycobacterium abscessus alone. So in disseminated disease, we have to give treatment for 6 to 12 months. So this is taken from the IC Journal 2019. Treatment for extrapulmonary non-tuberculous Mycobacterium diseases, the suggested regimens. If there is a macrolide resistance Mycobacterium abscessus detected, initial treatment should contain amikacin, cefoxitin, and imipenem plus tigecycline. If it's severe, 3 to 5 of the following antibiotics should be given. Clofazimine, linezolid, minocycline, moxifloxacin, clotrimazole should be given. If it's macrolide susceptible Mycobacterium abscessus or Mycobacterium malilens, severe initial we should use same amikacin, cefotaxime plus azithromycin if it's susceptible. For severe, azithromycin or clarithromycin, in which azithromycin is preferred with 2 to 4 of the following antibiotics: clofazimine, linezolid, minocycline, moxifloxacin, and clotrimazole. So what are the antibiotics? What are the challenges in the treatment? So this Mycobacterium abscessus has well known to have the antibiotic resistance. They develop biofilms which interfere in the treatment, and based on the colony morphology, we can tell whether the treatment outcomes were bad or good. If there is a rough colony, the treatment outcomes is bad. The important thing is, if this Mycobacterium abscessus, when it is faced with the antibiotic or any nutrient stress, it will grow a cell wall deficient state. At the time, it's very difficult to treat the Mycobacterium abscessus. In our patient, she was initially received meropenem and vancomycin for the infective endocarditis. After isolating Mycobacterium abscesses, she was started on amikacin, clarithromycin, and levofloxacin. As due to QTC interval prolongation, clarithromycin and levofloxacin was started. Then later changed over to imipenem, linezolid, moxifloxacin along with amikacin. For the brain abscesses, neurosurgery did not offer surgery as there is no mass defect. Thoracic surgery also did not offer as NTM has a high risk of prosthetic wall endocarditis. However, spine has offered wood debridement, which is not done as the patient is in heart failure and mitral regurgitation. They have opted for a comfort care and she has succumbed to her illness. Thank you.
Thank you, Monica. Can you go back to differential diagnosis? I know it's a case from HN4, but your differential diagnosis should include all the possible etiologies you'll think in a case who's presenting like this. And don't use spine meds when it's an infection. Meds is generally used when somebody has a malignancy. So this is obviously we need a good lab for us to make a diagnosis of non-tuberculous mycobacteria. And I think even in our lab, sometimes they can say they can ignore the organism as as a contaminant. So you do have to think of a possibility, and you have to tell them, we don't know what it is. Is it okay if you intubate for a longer time? And this condition has a high mortality. Did you show some data on? Did you show any study at all? Any case series?
No.
So you can't come to a clinical meeting and not have a case series, some data on how it's managed, some data from India. Just go back and show me what all you showed in your in your discussion. Medical therapy, few points. Next one. That's it. Just 2 studies. I think it's it's not enough. It's like there are some 25 people sitting here spending 1 hour. 1 hour is quite expensive for a doctor. This is this is not enough work. Okay. So any questions, Dr. Ramya?
In International Journal of Mycobacteriology, so we had 40 cases. Most common was Mycobacterium abscesses one, and a very high mortality. All our patients died, and like your patient also, most of them are associated with indwelling catheters like pacemakers or stents. Most commonly, they had come with stents. The only other thing I wanted to say is there is some our case series showed that some 55% are sensitive to linezolid also, in addition to clarithromycin and amikacin. But amikacin had the highest. Around 80% of the patients were culture had gone sensitive to amikacin. So, but very high.
So do look up. There are some case series which regularly comes from our different departments, especially from medicine. We have M5 which is published. Another common scenario which we see is people having surgeries and people using contaminated instruments. They get this abdominal wall infection, especially after some laparoscopic surgery. They come with multiple discharging sinuses. Do think of non-tuberculous mycobacteria causing the infection. You need extensive surgery to remove all those stuff and also antibiotics. Here, what's the risk factor for her? Why did she develop?
So she like one thing, the theories we can tell is she had a coronary angiogram in the past, and followed by she has a spondylodiscitis. So is the NTM causing the spondylodiscitis is the question.
So there's a good likelihood, isn't it? Most likely, she had a contaminated, angiogram. They used, contaminated, instruments for the angiogram, then developed mycobacteremia, caused this, caused that, and everything. We had another gentleman last month from Bangladesh who had angiogram, and he developed a Pseudomonas aortic abscess and also, involving the, one of the sinuses of, of the coronaries. Again, but he had multiple courses of antibiotics. So all the blood culture were negative. Finally, we grew something in the urine, which is sort of like a pan-sensitive Pseudomonas. But then he was also, high risk because ischemic heart disease. So we had to, they wanted us to go back home. So hospital acquired, where if the, the asepsis is not strictly maintained, you're at risk for all this. NTM is definitely a risk factor. Is a problem if it's not maintained. Any questions or any comments for Monica? Okay. Thank you, Monica. We'll move on to the next.